Good afternoon. I'm Marjan Askar. I'm very happy to be here at the virtual SAEM 21 to actually go into a very interesting session of, we have our presenters, Drs. Margaret Samuels-Kahlo, Dr. Sarah Cavallaro, and also Dr. Jessica J. Wall, presenting practice-changing research in pediatric emergency medicine, and really a synopsis of the best new papers. Excited to be here. We'll be monitoring the chat function and answer any questions that you guys have. And without further ado, I think Dr. Kahlo's first.
Great, thank you. Hi, everybody. I'm Sarah Cavallaro. Very excited to be here with you today to present to you the first couple of these interesting new and kind of cutting edge papers we have for you. Next slide, Jess. So we have no disclosures for you this morning, and we are going to kind of take these in turn. So I'm going to present to you the first couple papers. Next slide, please. So I'm going to pose to you a clinical scenario. So you have a 6-year-old previously healthy child who recently recovered from an acute mild COVID infection and comes to your emergency department several days later with 5 days of fevers and poor perfusion. And my question to you is, what are you going to do next? Which brings us into our first series of papers. Next slide. So these two studies I'm going to review with you first. I'm going to put them side by side for you since they cover a similar topic and were published at about the same time, so we can compare and contrast. They were both published in the New England Journal. And on the left, it is a multi-system inflammatory syndrome in the United States children and adolescents. And on the right, you'll see multi-system inflammatory syndrome in children in New York State. Next slide. So by way of background, in April of 2020 last year, a case series came out of the United Kingdom that described 8 healthy children in the middle of the COVID-19 pandemic that presented with cardiovascular shock, fever, and hyperinflation. And after that, here in the US, the CDC National Health Advisory issued a warning saying that we think we're seeing some new syndrome that they called multi-system inflammatory syndrome in children that we should be aware of and report and get more information on. Next slide, please. So then came along these two papers. On the left, the United States study collected patients between March and May of last year at 53 centers, and they used the case definition for MISE of hospitalized children under 21 years old who are presenting with more than 24 hours of fevers, 2 organ system involvement, labs of inflammation, and a SARS-CoV-2 infection, either by a good history of contact with somebody who had tested positive, a positive PCR test, or positive antibody test. Very similarly, a New York study published a paper on their patient population about the same time frame from March to May. They looked at 106 centers just within New York, and their MISE case definition was hospitalization and children under 21 years old with fever greater than 24 hours, and one of 2 criteria. Either they had signs of hypotension and shock, cardiac illness, or severe end organ involvement, or they had 2 or more maculopapular rash, conjunctivitis, mucocutaneous inflammatory signs, gastrointestinal symptoms, and no other diagnosis, and lab inflammation, and a very similar SARS-CoV-2 definition. Next slide, please. So this is from the United States study looking at where these patients came from since their centers span the country. And remember, this was published from patients last spring. So at that time, we were really seeing peaking in SARS-CoV-2 in the Northeast, which is where a lot of these patients came from. You'll see a big number of people in New York. Those patients were thrown out in the United States study so that we didn't double count them since the authors were aware of the New York study coming out at the same time. Next slide, please. So if we move on and we take a look at the results of when these patients were presenting with MISE, on the left you'll see the United States study, and on the right, you'll see the New York study. The top line there, which is in yellow on the left and black on the right, is when we were seeing SARS-CoV-2 infections. And then the bar graph, you'll see when these patients presented with MIS-C, and you'll see that they tend to present later than the SARS-CoV-2 infection, around 21 to 25 days after their initial infection, so a couple weeks later in both studies. Next slide, please. And if we look a little bit more closely at their results, so the United States study had 186 patients, to the New York study's 99 patients. The United States study, 70% tested positive for SARS-CoV-2, either by PCR or antibody testing. And remember, this was very early in the course of the illness, when testing was not as readily available as it is now. And 96% tested positive in the New York study. The number that kind of was jarring for us in pediatrics and kind of took us by hold was this previously healthy statistics, where the majority of children in both studies were previously healthy before they presented with MIS-C, and maybe a little bit of male predominance, perhaps an even split in the New York study. Next slide, please. If we look at the age, it really spans the age range of our patients. In the United States study on the left, we saw all ages, but tends to cluster really in that elementary school age. Similarly, in the New York study, the majority of patients were 6 to 12 years old, but definitely spanned all age groups. Next slide, please. When we're looking at race and ethnicity, this also got a lot of press. It seems that our minority populations were overrepresented compared to our white and our white non-Hispanic patients. The New York study published vital signs for us. So remember, you're not going to see fever here because by case definition, everybody had a fever. So looking at the other vital signs, the majority of patients were tachycardic, 97% overall. 78% were tachypnic, but 32% of these patients were presenting hypotensive, and only 4% were hypoxic, which was quite interesting since when we looked at these studies initially, we were comparing to acute COVID infection where we were very concerned with hypoxia, and this looked to be a very different entity as opposed to acute COVID-19. Next slide. When we look further at the organ systems involved, the United States study published data on how many organ systems were involved, and 71% of children had 4 or more organ systems involved. Remember, all these patients were admitted by case definition, but 80% in both studies needed ICU level care. 4% in both studies needed ECMO. 20% in the United States and 10% in the New York study needed invasive mechanical ventilation. And on top of that, 17% in the United States study and 23% in the New York study needed non-invasive mechanical ventilation. And each study had 2% deaths. Next slide. When we break it down even further, 90% in the United States study had 4 or more days of fever. And when we look at their symptoms, the most predominant symptoms seem to be gastrointestinal, with 92% in the United States study and 80% in the New York study. Next was cardiovascular system being involved, 80% in the United States study, almost half, 48% of those in the United States study, and 62% needing vasopressor support. And 50% in the United States study and 71% in the New York study having an elevated troponin. 76% in the United States study had some kind of hematologic involvement. 74% in the United States study and 61% in the New York study had mucocutaneous involvement. And only 70% in the United States study and 40% in the New York study had respiratory involvement. Of those that had imaging in the New York study, 39% had an opacity, and again, 2% in each study died. A lot of comparisons were being made to Kawasaki disease with these multiple organ systems involved, prolonged fevers, lots of inflammation. So the study both studies looked at if these children would have met criteria for Kawasaki disease if we were not seeing MIS-C, and 40% in the United States study and 36% in the New York study would have met criteria for Kawasaki disease, which led us to think about coronary artery aneurysms, which of course is the dreaded outcome of Kawasaki disease. We think about it in about 25% of patients with Kawasaki disease, and only 8% and 9% in the United States and New York study went on to have coronary artery aneurysms. However, much larger numbers had cardiac dysfunction. So 50% in the United States study and 52% in the New York study, as opposed to 5%, which is what we typically think about with Kawasaki disease. And in the New York study, this tended to be our older patients, our teenagers. 73% of those kids were the ones who were having cardiac dysfunction. This is from the United States study when we look at laboratory studies, and we were really seeing lots of signs of inflammation. So we were seeing elevated D-dimer and fibrinogen in the majority of these patients, elevated ferritin and ESR, very elevated CRPs, as opposed to the New York study, 100% of their patients had an elevated CRP, and we were seeing a pancytopenia, so lymphopenia, we were seeing anemia and low platelets in these patients. This is just descriptive. Remember, we were trying to put together a case definition when these papers first came out about what these patients were getting. So 70% in both were getting IVIG, 90% in the United States study got systemic steroids, and then there were other treatments, interleukin-6, interleukin-1 RA inhibitors, and anticoagulation therapy. So the limitations to this study, these studies came out right when we were trying to figure out exactly what this was, what we were seeing. So of course they're descriptive, very early in the pandemic when we still had limited COVID-19 SARS-CoV-2 testing. There's no comparison of treatments. This is all descriptive and very limited outcome data. So in conclusion, these two papers helped us in pediatrics to come up with an MIS-C case definition and compare what everybody was seeing. We learned that this seems to come several weeks after an acute SARS-CoV-2 infection, not at the same time. These children, the majority of them need critical care or intensive care, and they need cardiac follow-up because of their cardiac complications. But we don't yet have good treatment or comparison studies about treatment or outcomes. Next slide. Which brings us to our bonus paper. So this paper was published this late winter, early spring in JAMA, and finally gives us a little bit more data on what these patients have or their outcomes. And this looks at MIS-C and some severe acute COVID. And kind of the upshot, so this was a case series of 539 patients that they had with MIS-C across the country at multiple different centers, looking at what happened to them. So again, they got kind of a whole broad range of treatments, IVIG and steroids being the most common, also anticoagulation and antiplatelet therapy, immunomodulator therapy, hydroxychloroquine, and convalescent plasma across these patients. Their depressed left ventricular ejection fractions were a little bit lower than the prior two studies. Remember, the prior two studies were about half of those kids had myocardial involvement. In this study, only 34% did. Half of those who had heart failure were mild. And then coronary artery aneurysms, they were seeing about the same number, so about 13% of the kids in this study went on to have coronary artery aneurysms. And when we look at how these kids did, at 30 days, 91% had a normal EF, and at 90 days, almost everybody had a normal EF. And when we were looking at coronary artery aneurysms at 30 days, 79% of them had resolved, and at 90 days, everybody had resolved. So these kids seem to do well if we can get them far enough out in time. Great. I think that's it for my section. I am going to pass it over to Dr. Wall, but before I do so, does anybody have any questions for me? And we'll have time for questions at the end as well. Great. So I'm going to hand over to my colleague, Dr. Wall.
All right. We are going to dive into a couple of different clinical questions than MIS-C. So we're going to start with a case of a 4-year-old that presents to your emergency department, and you have given 2 doses of benzodiazepine. So at this point, how do you manage pediatric seizure in the emergency department, and what is really the best second-line therapy? So enter the ESET trial. As a background, status epilepticus is the most common neurologic emergency in pediatrics and adults. It is very established in the literature that first-line therapy should be benzodiazepines, but there's really no consensus on second-line therapies. And there were two studies that were done, the CONCEPT trial and the ECLIPSE trial, that demonstrated that levetiracetam was essentially equivalent to phenytoin in the pediatric population. That being said, until the ESET trial, no study had done a head-to-head comparison with valproate, fosphenytoin, and levetiracetam across age groups. The initial ESET trial was published in the New England Journal of Medicine, and this is a stratification by age group that was published in Lancet in early 2020. We're going to discuss this paper because it focuses specifically at 3 age groups and at pediatrics, and gives us some insight into our medical therapy for them. So the ESET trial was the established status epilepticus treatment trial. It was a multi-center clinical trial comparing 3 agents, levetiracetam, fosphenytoin, and valproate. They had a nice secondary analysis planned after they met their first endpoint to continue enrollment, and specifically in pediatric patients, to allow them to look at stratification by age group. The eligibility had to be a patient 2 years or older, and you had to have seizure for greater than 5 minutes despite adequate benzodiazepine therapy. And they allowed for doses of midazolam, lorazepam, or diazepam. So any of those 3 therapies, as long as it met the adequate dosing threshold. This was a double-blind study with a Bayesian response adaptive randomization, and they stratified by patients less than 18 years old, 18 to 65, and then greater than 65. And for our purposes today, we're going to focus on pediatrics. The primary outcome was the absence of clinically apparent seizures with improving responsiveness at 60 minutes after the start of the study drug infusion. All 3 study drugs were infused over 10 minutes, so there was a period of time that was allowed of observation for them to meet this endpoint. The results of the study demonstrated that there was no difference between treatment groups with regards to seizure cessation at 1 hour. So when you look across all 3 treatment types and across all 3 age groups, there was no significant difference between them, and specifically focusing on children on the left of the table, all 3 were roughly 50% effective. When looking at the side effects of these medications and sort of adverse events related to them, the life-threatening hypotension and arrhythmia were categorized together, and they were low in all 3 groups, thankfully, and were the same in all 3 treatments. Interestingly, this study had a finding that they didn't expect. It hadn't been found in the prior studies, that found intubation was more common in the fosphenytoin group than in the levetiracetam group or the valproate group. And it was statistically significant. This was a new finding. The authors stated this hadn't been found previously in the literature and needs to be investigated further. The limitations of this study, the primary outcome is a clinical finding. It's not based off of EEG. So it's possible that there was subclinical status that was missed. And the dosing may vary from current formularies. They used levetiracetam at 60 milligrams per kilogram, while some treatment protocols at the time were using 40 milligrams per kilogram. Fosphenytoin was in 20 milligrams 20 phenytoin equivalents per kilogram, and valproate was 40 milligrams per kilogram. The bottom line, though, is that all 3 treatments are safe and effective options for the treatment of benzodiazepine refractory seizures across age groups, and specifically in pediatrics. They have a similar safety profile with the exception of intubation, and there needs to be some more investigation to sort that piece out. That being said, what about seizures in neonates? So following this paper, there was another paper published in Pediatrics in 2020 that looked specifically at levetiracetam versus phenobarbital for neonatal seizures, a randomized controlled trial, given that ESET had looked at 2 and above, and there's now some safety data showing that levetiracetam is safe in the neonatal population. This was a multi-center randomized blinded controlled trial, looked at first-line treatment, so neonates often don't get benzos, for seizures in patients less than 2 weeks old, and they compared phenobarbital to levetiracetam. And notice it's a slightly lower dose than the ESET trial. Both arms had dose escalation, so they allowed repeat dosing up to a maximum. And then it was a crossover design if the seizure persisted. The primary outcome here was seizure cessation without recurrence in 24 hours, and this was done by continuous EEG monitoring. Interestingly, when you look at the primary outcome measure, phenobarbital was effective essentially 80% of the time, while levetiracetam was effective roughly 28% of the time, which was a clinically significant difference. The limitations of this study is it's a small sample size, limited ability to detect adverse events. It's a short-term endpoint. There's limited long-term safety data in neonates, but what it comes down to is, as well, the ESET trial did a wonderful job of showing the efficacy of fosphenytoin, levetiracetam, and valproate for seizure cessation in status epilepticus. In the neonatal population, looking at this paper published in Pediatrics, phenobarbital is more effective in neonatal seizures when compared to levetiracetam and should likely still be the first-line medication. All right, our next clinical question, moving on to a different topic. You have a 3-year-old that is brought into the emergency department by EMS after being the unrestrained passenger in a motor vehicle accident, and he is hypotensive. In pediatric trauma, should we still be using crystalloid and resuscitation for pediatric patients, or should we be moving straight to blood products? As a background, injury is the leading cause of death and disability in children, and hemorrhagic shock is the most common cause of preventable death. While traumatic brain injury is still the leading cause of mortality overall in pediatric trauma, hemorrhagic shock is the most common reversible cause. Evidence exists supporting crystalloid restriction and balanced transfusion, especially in the adult population. There is a lot of research that has been done that leads to us essentially not using crystalloid and moving on straight to blood products with a 1-to-1-to-1 ratio or whole blood. But the evidence is really less robust in the pediatric population. So enter this paper that was published in the Journal of Trauma, Acute Care Surgery in 2020, the timing and volume of crystalloid and blood products in pediatric trauma. This is an Eastern Association for the Surgery of Trauma multi-center prospective observational study. And this was the biggest paper to date looking at crystalloid restriction and blood product resuscitation in pediatric trauma. This was a multi-center prospective observational trial. Eligible patients had to be less than 18 years old and a trauma patient presenting from the pre-hospital setting. They had to have an elevated age-adjusted shock index, a SIPA, on first or second set of vitals to be included in the protocol. Exclusion criteria were greater than 20% burns or isolated burns, asphyxial injuries, or transfer from a referring hospital, as well as those transported to the emergency department by private vehicle or the police department. The primary outcomes were survival to discharge, and they also looked at ED disposition, ICU stay, ventilator days, total length of hospitalization, and inpatient complications. They initially enrolled just over 1,400 patients in this observational study, but they excluded almost half of those because they were transferred from another hospital. And their final cohort was roughly 700 patients. They had an average age of around 7.6 years, a slight male predominance, and the injury type was predominantly blunt, which is consistent with epidemiologic studies in the United States. Also, the majority of injuries were due to motor vehicle collisions, which is also consistent with current CDC data. There were 149 patients that were transfused. 28% of them received blood products before any crystalloid. And then the table here demonstrates that the more crystalloid boluses the patients received, interestingly, the higher they had a risk of being transfused as well. Their results overall demonstrated that greater than 1 crystalloid bolus prior to transfusion was associated with extended ventilator days, extended ICU days, and extended hospital days, essentially meaning we should not be volume resuscitating these patients with crystalloid. Greater than 1 crystalloid bolus was also not associated with a reduced need for transfusion. And this part is important, thinking about we're going to give some volume and then maybe we won't have to transfuse. And this paper demonstrates that that is not the case. There was the time to blood transfusion was associated also with extended ventilator days. And the authors were unable to assess for additional complications because there was a low incidence of the same in the study. The limitations of this study, one of the big ones was their inclusion criteria. They used an elevated pediatric age-adjusted shock index, which is overly sensitive and probably doesn't identify those patients that actually need early transfusion. 46% of the patients received crystalloid and only 20% of the patients received blood products, meaning that over half of their sample didn't receive anything, even though they had an elevated SIPA, again, meaning it's likely oversensitive. This was an observational study, which is also fraught with its own challenges. And then a large number of patients were excluded because they were transferred from another hospital. So this study was done at large trauma centers, and a good chunk of the pediatric trauma population presents to community hospitals and then require transfer. That being said, the bottom line for this paper, it is reasonable to transition to blood products early in resuscitation for pediatric trauma patients with signs of hemorrhagic shock, or even skip any crystalloid volume resuscitation initially and go immediately to blood products. And the general pattern of trauma in the world is beginning to move this direction. I think we're catching up to our adult data, but it's something to consider if your institution doesn't already have those protocols. And then while we're thinking about blood products in pediatric trauma, what about whole blood? That is becoming popular again and showing good efficacy in the adult population, but what about in pediatrics? So as a background, again, there's a paucity of data regarding balanced blood product resuscitation in pediatric trauma. What we do know is that massive transfusion in pediatric trauma has a high mortality, greater than 50%, meaning these patients are critically ill. Whole blood has been shown to be safe in pediatric trauma patients with signs of shock, but hasn't really been compared to a balanced blood product resuscitation strategy. This paper was published in the Annals of Surgery in 2020. And whole blood is superior to component transfusion for injured children. This was a propensity matched analysis. This was a single site that is a retrospective cohort study. Again, they propensity matched samples comparing balanced component therapy and whole blood therapy. They took advantage of a natural progression at their institution where between 2013 and 2016, they had component therapy only. And then from 2016 to 2019, they transitioned to whole blood. And as the years went on between 2016 and 19, the age cutoff allowing for the use of whole blood dropped into an age of 1 or greater. Their inclusion criteria were age 1 to 18, and they had to receive at least 1 blood product to be included in this comparison. The primary outcomes were resolution of base deficit and incidence of post-transfusion coagulopathy. The secondary outcomes were similar to the last paper: disability at discharge, hospital stays, ICU days, ventilator days, and total transfusion volume, all outcomes we care about in these patients. So the results of their study, when they compared whole blood to component therapy, they were able to propensity match 28 patients. They had over 130 in the study initially. They had 32 in the whole blood cohort. Of which 5 had to be excluded because of 5 had to be excluded because they had difficulty with when they received whole blood versus component therapy. So 28 were matched in whole blood to the component therapy, and they demonstrated that they had a fairly good balancing with their propensity matching. This table, I think, is the most profound out of their study. It shows the time to resolution of base deficit, and whole blood, the bottom solid line, dramatically outpaced component therapy in resolution of base deficit in the pediatric population. Also looking at additional outcomes. So all of their other secondary outcomes, mortality, functional disability, hospital length of stay, ICU and ventilator days, et cetera, there was no difference between the 2 groups. This study is small. It has a small sample size, and it is limited by being a single center study, which makes generalizability a little difficult. That being said, and they may also have had some improvement in resuscitation over time, given that their first cohort was 2013 to 16. They may have had improvement in their strategies from 2016 to 2019. That being said, The whole blood compared to balanced component therapy for pediatric traumas have similar clinical outcomes, but there was a dramatically faster resolution in base deficits and a small reduction in coagulopathy in whole blood over component therapy, meaning that whole blood is safe in this patient population and is likely beneficial. And before moving on to the next clinical case, are there any questions for me? All right, well, without further ado, Dr. Samuels Callow.
Thank you. Also, if people have questions and they don't want to say them out loud, they can put them in the chat and we can field them from there. So staying with the trauma theme, we're going to go and talk about a 15-month-old presenting with a humerus fracture. They come in with a fall that was reported at daycare, but otherwise look well. And really the question is any other workup needed for this injury? Next slide. So that brings us to this paper talking about trying to identify child maltreatment in infants and young children presenting with fracture, and in particular, trying to identify criteria for injury and for age. Next slide. So this was a systematic review looking at papers from 1980 to 2020. They identified 15 articles and used quality ranking to try and identify the highest quality articles to use for guideline development in a consensus process to create thresholds to try and identify injuries that were associated with abuse at different age criteria levels. And the thresholds that they used were injuries that were associated with an incidence of abuse that was over 10%, or a mechanism of injury that could not be verified by an individual that was unrelated to the child's care. Next page. The results demonstrated that 77% of children less than 3 years of age with rib fractures were diagnosed with abuse. And when you took out those who were known to have a motor vehicle collision, that percentage increased to 96%. 48% of children less than 18 months of age with humeral fractures, like our case, were diagnosed with abuse. And 34% of those with femoral fractures less than 12 months of age were diagnosed with abuse. And 25% of those who were less than 18 months of age. Next slide. Some limitations of this study include that there's no standard testing to determine child abuse. And they talk about this in the guidelines that they need to be addressed in the context of your local and regional resources. And importantly, despite the number of papers that were included in this consensus document, there are really a small number of cases in each of the studies that were included. There are also significant downstream consequences of child abuse reporting and known disparities in abuse reporting and evaluation. Next slide. But I think a conclusion in the take-home message is that routine evaluation for child abuse is now recommended for children less than 3 years of age who are presenting with rib fractures, particularly without a motor vehicle collision or other significant mechanism of injury to explain them, and for children less than 18 months of age who are presenting with humeral or femoral fractures. Next slide. I also wanted to highlight this paper talking about an emergency department high-risk bruising screening protocol. Not necessarily to say that your emergency department needs to have a high-risk bruising protocol, but really to talk a little bit about what a high-risk bruise might be. In this paper, they identify a high-risk bruise as any bruise in a child aged less than 6 months of age, or a bruise to the torso, ears, or neck in a child aged 6 to 48 months. These bruises are rare, but they're often associated with a diagnosis of abuse, and they should really raise your index of suspicion when you see one. In children less than 6 months of age in this study, only 0.6% had a high-risk bruise, or really any bruise at all. But of those, 50% were classified as likely or definitive abuse, and 38% had a positive skeletal survey, which is a really, really high number. In the kids who were 6 to 48 months, only 0.3% had high-risk bruising, but of those, 28% were classified as likely or definitive abuse. Next slide. We're going to switch gears and talk about a 6-month-old with vomiting who presents to your ED with mild dehydration. The child has good PO after Zofran, and what do you send them home with? And this has been a long-standing debate in pediatric emergency medicine about whether or not you're going to mask their symptoms of potential abdominal surgical disease, particularly appendicitis, if you send them home with Zofran. Next slide. So this study aimed to answer this question. A ondansetron prescription is associated with reduced return visits to the pediatric emergency department for children with gastroenteritis. They looked at a retrospective cohort aged 6 months to 18 years from 2012 to 2017 of children who were diagnosed with gastroenteritis, gastritis, vomiting, or vomiting with diarrhea. And part of the reason we wanted to highlight this study is because they had a really impressive sample size. So 82,000 patients of a median age of 4 years. So large sample size and a relatively young patient population. So exactly the group of folks that we would be worried about. Next slide. Ondansetron was prescribed to 13.4% of their cohort, and the 72-hour return visit rate was 4.7%. They found that patients receiving an ondansetron prescription had decreased odds of a 72-hour return visit with an adjusted odds ratio of 0.84. There was no significant difference between groups in the diagnosis of appendicitis on their return visit. Next slide. There are some limitations to this study. They were only able to capture return visits to their health system. It was done in a large healthcare system in Florida. And so their argument is that most children would have presented back to the same healthcare system, but it is still theoretically possible that children with appendicitis may have been treated outside of their healthcare system and therefore been invisible at follow-up. It's also unknown if the prescriptions were filled or used because they only captured whether or not the prescription was written. And in addition, the prescriptions were given based on the clinician's preference, and so the groups may differ in other ways. Next slide. But I think that the take-home message here is that ondansetron prescription was associated with reduced 72-hour return visits for children with vomiting or acute gastroenteritis, and importantly, was not associated with diagnosis of appendicitis on the return visit. And so we don't have to worry as much about masking potential surgical pathology and can treat symptoms of gastroenteritis with confidence. Next slide. And we're happy to use the last 10 minutes or so to take any questions.
Hi, thank you so much. I'll tell you, these are the themes that really come up when I'm working clinically, and this is so exciting. I can tell them I've got top-notch information to give the residents, which is something they're going to be hungry for. Any questions at all? I don't see anything. Are you guys monitoring the chat? Any questions at all? Okay.
If there are no questions, the three of us will stay in the Zoom for a few more minutes just to see if anything comes up. But we want to thank everyone for listening.
Thank you so much for being here. I'll also be here just in case, and maybe we'll see you guys in other conferences throughout the next couple of days. Thank you.
And to answer, it looks like Julia's question came in. Can we share the links to the articles? I don't have those readily available, but we will share the slides that will have all of the titles of the articles here, and we can see if we can include them in the chat before we finish.
Thank you very much.